So again, thanks to ISO and thanks to Dr. Sumant and Dr. Bharat for this invitation. So my presentation is going to be very brief and very focused just on the role of maintenance therapy in advanced urothelial cancer. So this is the schema of my talk. So I will first sort of talk about the background of why you need maintenance treatment in urothelial cancer, the rationale, the scientific rationale behind it, what are the switch maintenance options in terms of chemotherapy versus immunotherapy, both in and also maintenance after first line chemo IO combination, and most importantly, how would one sort of take this forward into our clinical practice. So what is the background for maintenance strategy in urothelial cancer? Remember, in advanced or metastatic urothelial cancer, the efficacy of first line chemotherapy, even in a patient who's eligible for cisplatin, the response rate is of around 75 to 80%. With cisplatin-based chemotherapy, the median progression-free survival is only around 8 to 9 months. And this is in the clinical trial setting among patients who are really fit. So obviously it would be much lower in our real world setting. And when we look at a median overall survival, patients who've at least been eligible to take some cisplatin would have a median overall survival of anything from 14 to 15 months. And if you were not cisplatin eligible and you took carboplatin, your median OS comes down to say 9 to 10 months. So this is definitely an area of need, in terms of a need to improve the overall survival of patients with metastatic urothelial cancer. So in terms of what has been done before this, maintenance chemotherapy with a drug called vinflunin, there is some phase 2 data from Spain. Now, remember, all these maintenance trials, they all included patients who had what was called a disease control with platinum-based chemotherapy. Now, this essentially means that you take patients who have not progressed on platinum. So the patient could have had a complete response, a partial response, or even stable disease to platinum chemo. And so at their median follow-up was around 15 months. So obviously, if this was compared with placebo, so there were less progression, 66 versus 84% in the arm which received vinflunin. And the median OS went up from around 13.2 to 16.7 months. But vinflunin, again, I've never seen the drug. It is not available here. And this is a phase 2 trial. So what is the rationale for using maintenance immunotherapy in urothelial cancer? So again, a little bit back to the basics. Urothelial cancers have high levels of PD-L1 expression. And we know that among cancers like melanoma, lung, and urothelial cancers, there is a higher tumor mutational burden when compared to other cancers. Now, this has somehow sort of been associated with a response to immunotherapy agents. Now, we also know that there is some data, say like in the Pacific trial in lung cancer for maintenance immunotherapy following chemotherapy in other solid tumors as well. And now in terms of the molecular level, chemotherapy does enhance the effects of subsequent immunotherapy. Now, this can be because of two things. One, it can, because of immune priming, it depletes immunosuppression. And of course, these are not cross-resistant. And most importantly, and I think from a real world perspective, what percentage of patients with advanced urothelial cancer, even if they are cisplatin eligible, actually are able to get on to a second line systemic therapy? I think for us, for the science aside, this is quite important in our decision making when it comes to maintenance in urothelial cancers. So the first data in favor of immunotherapy was actually with pembrolizumab. This was again a phase 2 data. This was presented in the ASCO 2019. And so this looked at around 100 odd patients with, remember, all these maintenance trials took patients who responded to chemo. So they selected out the best of the best. And most often, all these trials exclude patients receiving neoadjuvant chemotherapy within 1 year of randomization. So they're very selective about who they choose. So again, this was patients with metastatic urothelial cancer who had at least stable disease on first line any platinum. And these patients were randomized to an intervention which was maintenance pembrolizumab every 3 weeks for up to 2 years. And of course, it was a placebo-controlled trial. And the crossover was allowed because pembrolizumab, we know immunotherapy is a second-line treatment for patients who fail first-line chemotherapy. And their primary endpoint here was not overall survival, it was progression-free survival. So what they set out to look for, they wanted to demonstrate a progression-free survival benefit, and the PFS benefit was 3 versus 5.4 months. That hazard ratio was 0.65. And the OS, remember, if you actually looked at the vinflunin data, this and the average OS as described in the traditional chemotherapy papers, look at this median OS. So the placebo arm itself did so well. The median OS was around 18 months and 22 months in the pembro arm. And they also wanted to look at if a PD-L1 CPS of more than 10 was predictive for better progression-free or overall survival, and there seemed to be no interaction. Then we will move on to the first phase 3 randomized trial, which was the Javelin Bladder 100 trial. So this is again, sorry, just a second. Yeah. So, okay. So this is maintenance avelumab, same strategy. Select out patients who respond to first-line chemotherapy, platinum-based chemotherapy. Patients were randomized to avelumab versus best supportive care. And here their primary endpoint was overall survival. And they stratified patients as per the PD-L1 expression and also the secondary endpoints like PFS and safety and tolerability. So again, to highlight their exclusion criteria, they excluded patients who received adjuvant or neoadjuvant therapy within the last 1 year. So these patients we know who fail after initial curative intense adjuvant or neoadjuvant treatment within 1 year tend to do badly. So they excluded these patients. Now, this is the baseline characteristic table. So what I'd like to highlight here is that majority, around 70 odd patients were bladder cancer. And there is data even to include patients with upper tract. So remember, upper tract, again, urothelial cancer is very poorly studied. And around 25 to 30% of patients in either arm did have upper tract cancers. And PD-L1 positivity as defined by an SP263 of more than 1% was around 50% of patients in either arm. And again, patients mostly had GEM-CIS. So this is obviously to sort of reason it out, most patients who would have been treated with the neoadjuvant intent with, say, accelerated MVAC, that's probably, and if you were de novo metastatic, you would just get on to cis or carbogem rather than an accelerated MVAC based regimen. And around a third of patients had a stable disease, and the rest, around 70%, responded to the chemotherapy. So when we look at the overall survival, which is what they set out to look, again, the curve on top shows actually the overall survival for the overall population. This was around 21.4 versus 14.3 months. The hazard ratio was 0.69. And when they looked at their stratification factor, which was the PD-L1 positive population, the median OS in the avelumab arm was not reached, and the control arm was around 70. So remember, in the pembro and the avelumab trial, the OS was much better. This is because they selected out a very favorable population of patients. When they looked at progression-free survival, a similar trend was seen. The average PFS benefit with avelumab was around 3.7 versus 2 months, and the numbers seem quite significant. So then we move on to what is this, at what expense does this come at? So when we look at the toxicity profile, so overall grade 3, grade 4 toxicity was higher with maintenance avelumab, 47 versus 25%. But remember, this is again a very morbid population that we're looking at. Most of these patients would have, say, obstructive uropathy, would have renal dysfunction. So we would expect high rates of grade 3 toxicity anyway in both arms. What I want to highlight is that the risk of a grade 3 or higher immune-related adverse event in the avelumab arm was only 7%. So most of these grade 3, grade 4 adverse events were actually non-immunotherapy related, if I can put it that way. So then we move on to data favoring use of immunotherapy in patients who receive chemo and immunotherapy as the first line. So this is again a short data set from the IMvigor 130 study design. So if we all recollect, atezo single arm was given an approval based on a phase 2 data set in platinum ineligible patients. So this trial actually set out to sort of corroborate that, and they had 3 arms: the atezo with chemo, atezo monotherapy, and a placebo with chemo. So here, what they are comparing is the arm A and arm C. So addition of atezo and to chemo versus placebo and chemo, and their they had co-primary endpoints of OS and PFS. So just to summarize for you, this was around 12,000 patients, and they managed to show a PFS benefit of 8 versus 6 months with in the atezo arm, which obviously included atezo maintenance in responders. The OS data isn't mature, so the interim OS data is around 16 versus 13 months in favor of atezo. Now, this is my last slide. So how do we sort of take this forward in our clinical practice? So if you look at just the data, well, switch maintenance with immunotherapy, the Javelin trial, Javelin 100 trial, avelumab, uh, well, it does work in patients in a select group of patients who respond to first-line platinum-based chemo. It prolongs progression-free and overall survival. And these are again patients who have not had chemotherapy in the neoadjuvant or adjuvant setting or in the past 1 year. Now, what is this really? I mean, is this really an extension of first-line treatment, or obviously is a maintenance strategy just early second-line treatment? And that brings us to more questions like, is this benefit sort of driven only by the PDL1 positive population? Is there even a benefit in a PDL1 negative population? And in our setting, when you talk about decision making in our setting, should we really opt for things like maintenance avelumab versus a second line immunotherapy regimen if a patient can take it? Should we just go and offer it upfront or wait for a patient to progress and then give the IO? And then what do we do if somebody progresses on the avelumab? And also remember, unlike in the West, where patients with bladder cancer have access to clinical trials and other targeted agents like erdafitinib and enfortumab, our patients don't have access to this. So, should we really give the immunotherapy upfront as a maintenance, or should we reserve it for the second line? So, these are my thoughts, and I'll stop with this. So, thank you.